Hello, everyone, and welcome to Conversations in Interventional Cardiology. My name is Sandeep Nathan. I'm a professor of medicine at the University of Chicago, where I'm also a practicing interventional cardiologist. I also serve as an associate editor for JSCAI, and it's my absolute pleasure and privilege to serve as a moderator for this evening's discussion. I'm honored to represent JSCAI on behalf of Editor-in-Chief Dr. Alexandra Lansky. Please follow us online at jsky.org and on X, formerly Twitter, at myjsky. JSCAI, I'll remind everyone, is the official site for all SCAI documents. We're here today to discuss a very interesting research letter that's being published in JSCAI titled, "Are There Disparities in the Utilization of the Impella Device in AMI Shock in the United States?" I'm joined by an esteemed panel of SCAI leaders and experts, Dr. Zaid Almarzooq, who's a fellow in cardiovascular medicine at Brigham and Women's Hospital, Dr. Mauricio Cohen, Director of Structural Interventions at the Heart, Vascular, and Thoracic Institute in Cleveland Clinic, Weston, Florida, and Dr. Bobby Ye, Professor of Medicine at Beth Israel Deaconess Medical Center in Boston, Massachusetts. Welcome, everyone, and thank you for joining me. I'm going to turn it over now to Dr. Almarzooq to share his slides and get us started with a summary of the study.
Great. Well, thank you very much for inviting us. And on behalf of my co-authors, I'll present our paper entitled, "Are There Disparities in the Utilization of the Impella Device in Acute Myocardial Infarction and Cardiogenic Shock in the United States?" I have no disclosures. To start, our group has previously demonstrated in the figure on the left that hospitalizations for cardiogenic shock have increased, while at the same time, a more recent study evaluating the outcomes of the Impella device showed that the use of Impella has dramatically increased since its introduction to the market in 2008, emphasizing the growing use of the device in our daily practice. In another more recent study that our group had performed, looking at the utility of different methods and evaluating different clinical questions related to the Impella device, we had identified a signal for higher use in minority-serving hospitals. In this table here, showing two categories of hospitals, those that are considered to be in the lowest quintile of Impella users and those in the highest quintile of Impella users, you'll notice that those in the highest group had a higher or a greater population of Black race patients, as well as they were more, in addition, they were more likely to be considered minority-serving hospitals. And this prompted our current study, where we evaluated a CMS fee-for-service population, identified a group of patients that had presented with acute MI and cardiogenic shock who had underwent PCI and received an Impella. That was around 9,138 patients, and really stratified them based on several groups, including age, sex, race, and socioeconomic status, defined by dual eligibility for Medicare and Medicaid. And here, the population had a mean age of around 73, and about 2/3 were male. And what you see here in this figure is the annual Impella use during the study period of 2015 to 2021. And we stratified them by age using a cutoff of 74. And you'll notice that the annual rate did increase, and it was consistent among both groups. And the mean annual rate was around 2%. The same annual rate was seen among different sex groups, both male and female, different race groups, Black and white, as well as different socioeconomic status groups, low versus non-low. We then looked at trends in unadjusted 30-day mortality among the same stratified groups, and we noticed no change in unadjusted 30-day mortality during the study period, and that was not different that was sort of the same among all subgroups. And it was sort of close to around 55%, emphasizing the very high mortality associated with cardiogenic shock. We therefore concluded that Impella use has continued to rise since its initial FDA approval. In the study, we did not identify any significant disparities related to race or socioeconomic status in the dissemination of the Impella device. And while there were no changes in unadjusted 30-day mortality, the mortality rate in patients with acute myocardial infarction and cardiogenic shock continues to be high, emphasizing the need for current interventions or innovation in this field. I'll stop there and I'll take any questions.
Well, thank you for that overview of this important paper. So there were about 10,000 patients included in this data set. And this was a CMS data set. So by definition, all these patients are above the age of 65. And you essentially looked at socioeconomic status by clustering Medicaid and Medicare dual eligibility. Is that right?
That is correct.
So let me ask you: are there other ways to look at socioeconomic status, or to rephrase it, is there any reason to believe that other ways of looking at socioeconomic status would come up with a different conclusion? I think it's fantastic that everyone across the board is getting seemingly equivalent or comparable care, at least with respect to MCS, when they present with shock. But are there other ways to sort of slice this data that might portray it differently?
I'm sure there is. And I think it really depends on how you define socioeconomic status. And I think in this case here, by defining it using Medicaid eligibility, we sort of really framed it based on income. But there are certain other ways, and maybe I'll hand it over to Bobby in terms of other ways that you might have looked at socioeconomic status in the past.
Yeah, sure. Dual eligibility really is probably the best individual measure of socioeconomic status that we use in Medicare. It's been highly predictive of a lot of different aspects of disparities in care and poor outcomes. And the reason we like to use it is because it identifies really specifically the individual. And while Medicare dual eligibility differs based on Medicaid eligibility rules that differ from state to state, for the most part, they are defined by being, having an income of some percentage near or thereabouts the federal poverty limit. So it makes it a consistent way to look at individual patient data. Now, there are other surveys that we sometimes use that can generate things like community levels of socioeconomic status, like the social deprivation index or the area deprivation index or other measures of it. There are data from the American Community Survey, which can look at income and education levels, but those are, again, by community. And sometimes those can drown out effects. We've often done analyses where we've looked at both to understand whether it's an individual level effect or a community level effect. But here we really wanted to look at the individual level because we thought it would be unlikely that necessarily, the community would affect things apart, in a different way than the individual socioeconomic status.
So there are other ways to do it. We've done it before in some studies that are published a few years ago. I think you can also look at the zip code, right? And the median income of the zip code and then assign a particular income level to each one of the patients and divide that across different quintals. I mean, that's a very granular way to doing it. And maybe the way you did it is more simple and more straightforward.
Yeah, that's what I mean when we use the ADI and the social deprivation index and data from the American Community Survey. It's usually based on linking by zip code, either 5-digit or 9-digit zip code. So it's a sort of a community level variable as opposed to an individual level, because even within a certain zip code there may be diversity of income and education, and so certainly analytically it's not hard to do it either way, honestly, but for this analysis, we chose to look at dual eligibility specifically.
Now, patients being cannulated for ECMO were excluded from this data set. Is that right? So this was just pure Impella, and it was percutaneous only, or inclusive of 5.0 Impella during that time frame?
Well, it was, we did exclude patients on ECMO, just given the fact that there does seem to be a stratification in terms of how bad the cardiogenic shock is based on what device you get. But nevertheless, it is hard to tease that out. And so by focusing on Impella, that was one way just to look specifically at that device. In terms of what Impella device was used, it is very hard to determine what device was used. But based on clinical practice, we know that it's likely Impella CP or one of the more common Impella devices used, compared to the 5.5, which actually came probably into the market towards the latter, almost towards the end of the study period. But the ICD codes used do not differentiate Impella device type.
Yeah. Mauricio, you're about to say something?
Yeah. So do you think that having protocols for the management of cardiogenic shock may tend to eliminate disparities? We looked a few years ago at the implementation of quality improvement strategies. And we saw that hospitals that actually implement a quality improvement strategy tend to make processes more uniform across different socioeconomic status, gender, and race differences. And I think that over the past years, there's been a very strong emphasis into protocolizing the management of shock and that could probably lead to the elimination of disparities. Maybe a far stretch, but I would like to know what your thoughts about that are.
Yeah, I think certainly. I think one of the things that, as I look at the data, it sort of emphasizes that the use of the Impella certainly requires a lot of resources, and certain these hospitals often will have a cardiogenic shock team, and that really brings in together various members of different teams together. And so, to your point, it may lead to less disparities, may emphasize why. And I think part of it is because sort of the hospital is coming together to really sort of focus on this patient and ensure that they get the best care.
And then there's a National Cardiogenic Shock Initiative, right? That mostly bases the protocol surrounding Impella, right?
That is correct, but there's only sort of a certain number of hospitals that are part of that. And so we did include hospitals that were part of the shock initiative, the NCSI or the National Cardiogenic Shock Initiative, and those that were not. So it does include both groups.
The final roundup of the NCSI data was 406 patients, and if I remember correctly, it was about 80 hospitals. And what was nice about that data set was that it was a sort of an even split between academic medical centers and community medical centers. And I think, what that tells us is, as you, I think, are alluding to, Mauricio, you build a protocol and it's more widely, implemented than just sort of defaulting to local practice. So, it's interesting because, the first few years of my career, I was at Cook County Hospital, one of the largest safety net hospitals in the United States, very, very busy ER, very busy cath lab, and so forth. And I really never felt that for critically ill patients, we were thinking about their socioeconomic status or, where they came from or, their ability to pay for the aftercare and so on and so forth. Do you think that that's sort of the driver here? Because in many other less acute procedures or service lines, you do see disparities across the country. Do you think it's just the urgency of the situation that's sort of homogenizing the population?
I think there's a few factors that lead to this. I think one, that the acuity of the presentation of these patients brings them to the hospital. So the issue of access is no longer there, or the question of access gets sort of put aside. And then once the patients are there, your hands are forced to really act on the information or the acuity of the patient to ensure there's a change in the clinical course. Compared to other conditions or other novel devices like the TAVR device, for example, where our group has looked at the dissemination of the device or the use of the device. And we've noticed that when we look at racial disparities among TAVR use, a lot of times the issue or the disparities tend to occur because of lack of access to either echocardiography and access to getting a diagnosis or access to coming to the hospital. But once they do make it to the hospital, oftentimes they do get the right treatment. Bobby, any other points?
Yeah, I mean, before we started this, Mauricio was, highlighting important previous work that demonstrated that even in some acute situations, there remain disparities. And I think that was a great point. And then I like to think that, we've improved and been more cognizant of those disparities now, and maybe things that have shown up in, maybe that would have shown up 20 or 10 years ago are not showing up now because we're all more sort of aware of our potential cognitive and unconscious biases. But, this is really, a null finding we thought is important. This is the absence of disparities is important. It's a demonstration of progress. It's a part of FDA's CDRH's strategic initiative to really understand disparities of device dissemination. So it's nice to put forward a story which we show that maybe we're doing an okay job here. Whether or not we actually know how to treat these patients, I think, is a different question. But at least there are not large disparities that we're identifying.
Do you guys think that the results of upcoming clinical trials, I think DanGer will be presented in the near future, may change the landscape in one way or the other? It seems that it's very difficult to alter the outcomes of patients with cardiogenic shock.
Yeah, I think that's going to be a really important trial. I'm eagerly looking forward to seeing what the result is. I know that everybody on the call is, and many in the audience will be too. But I'm also, skeptical. I have my skepticism about how long that trial took to enroll and the potential limitations of really studying this question in the context of a sort of a randomized trial that took, a long time to complete. I hope that it gives us information that helps us treat patients. And I hope that it gives us a definitive answer, but one way or another. But I'll cautiously optimistic, I'll say. Curious what others people's are thinking as well.
I mean, I think the two challenges in this space, two among many challenges in this space, is the discomfort with coin flipping. When you have a critically ill patient and saying, you know, you get device, you don't get device. That's problem number one. Problem number two is crossover, right? I mean, any amount of crossover. This isn't going to be a 10,000, 20,000 patient study like many pharma trials. You know, in a small trial, even modest amounts of clinically necessitated crossover is going to start to bias towards the null hypothesis. And I just don't know how you get rid of that in these kinds of trials. Open to suggestions how we fix that in clinical trials, because, if history is any guide, all of these trials have failed to show a meaningful reduction in mortality if you're just purely randomizing.
Yeah, Holger Thiele has got this great slide that he talks about, which is that, with the mortality being so high in all these trials, he's always asked why he runs negative trial after negative trial in this space and what are the challenges. And one of the reasons he said is because, well, if you think about it, we're starting with 50% mortality no matter what we do. And so there are some patients who they're just coming in too late in the game, and the devices aren't supplying enough cardiac output, whatever it is, they're just going to die no matter what we do, unfortunately. And then there are other patients who they're going to recover no matter what we do. And we know that 50% of patients recover, 40 to 50% recover, and that's what they've been doing for a long time. And so it's really, we're trying to find that narrow sliver of this population that's going to recover with the device and not make it without. And depending on how big you think that sliver is, no matter what, it's probably not a humongous sized of a population involved among the entire denominator. And so you have to find a trial that's going to be powered enough to find that exact small population of benefit. And so exactly what you're saying, Sandeep, that let's say that one recoverable patient is the one that you keep out of the trial, or the one that crosses over, maybe that would be the most likely patient to cross over in this setting. And then you can diminish what might be a really difficult defect to discern anyway. So really challenging space for sure.
Well, Zaid, I'm going to give you the final word here. Maybe share with us future directions for this line of investigation. I think it's very promising and very reassuring that we're sort of applying this technology uniformly. Final thoughts?
No, thank you very much for allowing us to present our paper. It certainly highlights what we're doing well, I think, and certainly when it comes to novel devices. But I think more importantly, we need to understand why and what we've done differently here. And I think hopefully future studies will look into that. We'll also understand probably different aspects of disparities, looking at geography, looking at other sort of markers of disparities. But I see certainly there's a lot of opportunity to understand this better.
Well, on behalf of SCAI, I think that's a wrap. Thank you so much, Mauricio, Bobby, Zaid, and thank you, SCAI, for supporting this. And big thanks to the audience for joining us today.